Thank you so much, Alan. The first session is going to be chaired by Dr. Tashree couldn't be here today, and she's reshuffled her schedule, so it's going to be chaired by Dr. Mahajan and Dr. Zucker. I want to introduce the first speaker, and it's going to be Professor Doug Zipes. And it's hard to say anything about Dr. Zipes that doesn't sound like a rave review, mainly because we're highly biased. We're electrophysiologists, and he's one of the few electrophysiologists who really engaged basic scientists who were working in the field of autonomics and really got us interested in really looking at arrhythmias and how to manage this. And in fact, the signature procedure that is offered for neuromodulation, and perhaps the first intervention that is effective for managing a cardiovascular problem, is cardiac sympathectomy, bilateral sympathectomy, that was first done by Dr. Zipes. So we could fill up one entire morning of this conference just to go over the papers he has published. But I'd love to introduce him and invite him up. And it's quite appropriate that he gives the first talk for what is a very interesting and important symposium for us.
Thank you.
Welcome, Doc.
Thank you. Thank you, and it's a pleasure to be here and to kick off this second annual symposium. Okay, may I have the first slide? I guess I click on it. Wait a minute. I have it on the computer. There we go. Okay. I've chosen to talk about spinal cord stimulation, which is an area that we've been interested in for some time now, and give you a brief history of where it's been and where I think we're going. I have no conflicts. Dorsal column stimulation for pain relief is rather old and has been used for back pain and for a variety of things. And indeed, one of the very early studies by Dr. Foreman and his group attempted to determine mechanisms that might be responsible for this and demonstrated that spinal cord stimulation excited inhibitory neurons in the dorsal horn that inhibited sympathetic neurons. And you can see here the pointer's not showing up on that. No, wrong one. How does this pointer work? Okay, thank you. This stimulation artifacts, but it inhibited sympathetic neuron activity, as you see there. So that was one of the first explanations for why spinal cord stimulation might be effective. And indeed, it was followed by a study, this is in humans, measuring total body norepi overflow in patients who had angina-induced pacing with atrial pacing, showing an increase in total body norepi that was then prevented by spinal cord stimulation, certainly consistent with the animal data previously. When I first got involved, I was reminded of an observation by a very sage clinician, Sam Levine, that carotid sinus massage could eliminate angina in patients. And indeed, spinal cord stimulation was being used for these patients. And I wondered whether there might be a vagal effect from spinal cord stim. And indeed, that had been capitalized on by Gene Brownwall many years ago by treating patients with carotid sinus stimulation who had intractable angina. So we raised this as an hypothesis. and we're very interested in the T1 to T4 area, and set up a series of experiments in which we stimulated with epidural leads in this particular area of the spinal cord. And this was one of the first publications. Jeff Olgan was first author of this. And this shows data of spontaneous sinus node activity in dogs during baseline and then during spinal cord stimulation. And the scales don't actually show the significant change. But in each instance, spinal cord stimulation prolonged spontaneous sinus cycle length. And despite increasing sympathetic stimulation, spinal cord stimulation was still able to prolong sinus node activity, sinus node cycle length, and it was in addition to cervical vagal stimulation. So in each instance, spinal cord stimulation prolonged sinus cycle length, prolonged AV conduction as well, and these effects were eliminated when we cut the vagus. So it seemed that at least part of spinal cord stimulation effect on the heart was vagomimetic via cervical vagal transmission. We then were interested because vagal stimulation should be anti-arrhythmic in ischemic models, to create an animal model where we could produce ventricular arrhythmias and stimulate the T1 to T4 area via an epidural lead in the spinal cord area. We also had ICDs implanted to monitor electrical activity. And I wanted to replicate a clinical model that we see in our patients. That is, a scar from an infarct, heart failure, and angina, which is a common clinical scenario. So we gave dogs an infarct, we rapid paced to produce heart failure, and then we transiently occluded the circumflex to replicate a patient with angina. And we were able to produce both polymorphic and monomorphic, these slides are out of order, monomorphic ventricular tachycardia in these dogs. In the control state, in this particular group of experiments, 13 dogs had VTVF, 9 did not, and then during acute spinal cord stimulation, we were able to significantly suppress the spontaneous onset of ventricular tachyarrhythmias in these dogs. Interestingly, shortly after, a lovely publication by Sutherland et al. This is in rabbits looking at infarct size, and they demonstrated that what they call preemptive spinal cord stimulation, that is spinal cord stim prior to the coronary occlusion in these significantly reduced infarct size in these rabbits. Presumably again through either a vagomimetic and or sympatholytic effect. So the spinal cord stim not only has a functional effect on the development of spontaneous ventricular arrhythmias, but here an actual measured anatomic effect as well, reducing infarct size in this group of animals. We then carried this further and wanted to ask the question, what about duration? Could we produce spinal cord stim that had a longer effect, and what might that be? So once again, we made our infarct rapid paced, but now we treated dogs for 5 or 10 weeks with spinal cord stimulation and had 4 groups of dogs with comparing spinal cord stimulation against optimal heart failure treatment as well. So we had a control group, spinal cord stim, a group treated with ACE inhibition and carvedilol, and then a 4th group with drugs plus spinal cord stimulation, and monitored these dogs for 5 to 10 weeks or so. And here you see just some of the data. So these are serum markers, serum BNP in baseline in the 4 groups of dogs. So we have spinal cord stim plus drugs, drugs alone, and then control. And then after infarct and heart failure, significant increase in BNP as one would expect. And then spinal cord stimulation here at 10 weeks, significant reduction of serum BNP in these dogs. Serum norepi increased dramatically after infarct and heart failure and was reduced quite significantly by spinal cord stimulation. This is left ventricular end diastolic dimensions. Dogs develop ventricular dilation, as one would expect, with the onset of the infarct and heart failure, and then there was significant reverse remodeling of heart failure in these dogs. This, I must admit, came as a surprise to us. We were most interested in the functional effects on arrhythmias, but indeed demonstrated reverse remodeling. This is end diastolic dimensions, and systolic dimensions were reduced as well. Spontaneous ventricular arrhythmias increased and then were suppressed by spinal cord stimulation. And then ejection fraction, which started at close to 60%, fell to 18% in these dogs after heart failure and infarct. And in the spinal cord stim dogs had the greatest return back to normal. So this was a new observation for us, that spinal cord stim could reverse remodel and indeed appeared to have a major effect on heart failure. We were interested in where the optimal stimulation site might be, and took another group of dogs with different levels of spinal cord stimulation. So this was 90% motor threshold at T1. This was spinal cord stim at T4, 90% motor threshold. T4 at 60% motor threshold. T4 at 30% motor threshold. And at T8 at 90% motor threshold. And just to summarize data, these are the groups of dogs showing ejection fraction normal, falling significantly, and those dogs that had 90% motor threshold at T1 or T4 or 60% at T4 had the greatest improvement in ejection fraction, while stimulating 30% motor threshold at T4 or 90% at T8 did not produce the maximum effect. So it would appear that someplace between T1 and T4 at anywhere from 60 to 90% motor threshold had significant impact on ejection fraction and reverse remodeling. So from these data, we concluded that stimulation at those sites improved contractile function, decreased ventricular arrhythmias in this canine model of heart failure. And since that publication, there have been multiple studies in various heart failure models by other investigators that have found similar kinds of results. Interestingly, if one looks at some clinical data now, these are other publications in the literature. This was a publication in Heart Rhythm several years ago in 2 patients with ventricular arrhythmias who had a significant reduction of ventricular arrhythmias with spinal cord stimulation. And interestingly, patients had ICDs, and despite spinal cord stim, there is no recording of the stimulation artifacts by the ICD. This becomes critically important because if you're going to do spinal cord stim in patients with ICDs, you don't want crosstalk, and indeed they demonstrated there was none. Another paper in PACE showed increase in heart rate variability in 8 patients with spinal cord stim, and EuroPace by Ferrero et al. That spinal cord stim reduced T-wave alternans in 3 patients. And I show this study, which may be familiar to some people here, just to show how modulating the spinal cord might affect ventricular arrhythmia. So this is a group of patients who had significant ventricular arrhythmias and had thoracic epidural anesthesia in these 8 patients with a significant reduction in ventricular arrhythmias. So it's clear that modulating spinal cord activity via multiple potential mechanisms does impact on ventricular arrhythmias. Well, based on these data, I was fortunate enough to convince Medtronic to support a clinical study of spinal cord stimulation in patients. This is called the DEFEAT-HF, Determining Feasibility of Spinal Cord Neuromodulation for Treatment of Chronic Heart Failure. I was the PI in US and Heinz Therese in Europe. And our hypothesis was, based on the animal data, that treatment with spinal cord stim could reverse remodel patients with New York Heart Class 3 heart failure and normal QRS complex. So they were not candidates for CRT therapy. Primary outcome was change in left ventricular end systolic volume index over 6 months, with secondary outcomes in peak VO2 and NT-proBNP over 6 months. We had the usual external monitoring committees, as one sees here, and this is a group that participated, and I show this to make the point that the Czech Republic recruited a third of our total subjects, and one needs to take into consideration potential imbalance. It turns out the statisticians tell us there was none, but nevertheless, they did a heroic job in recruiting these patients. Eligibility was New York Heart Class 3, EFs 35% or less, normal QRS duration, dilated ventricle, stable medical therapy, and patients then received an epidural electrode at generally a T2 to T4 level. It was a single lead. Implant procedure is standard because this is used for pain, as I indicated. Stimulation was for 12 hours a day based on the patient's sleep-wake cycle. We avoided stimulating at night because the epidural lead can shift its position when someone becomes supine versus upright, and we didn't want to change in stimulation parameters. 50 hertz, 0.2 millisecond, 90% maximum tolerated voltage. Trial design was implant randomized 3-2 with spinal cord stim versus control. They received implants, but it was not turned on. Single blind follow-up, as one sees here, and after 6 months, the control group had spinal cord stim turned on, and these patients were then followed. So we started with 81, several were excluded. We randomized 66, 42 to spinal cord stim on, 24 off. We lost one patient at a 6-month visit, and in the control, similarly, several patients were lost. So we analyzed then 40 based on intention to treat, and 20 that were in the control group. So this was a rigorously done prospective controlled randomized trial. Patients were equivalent in terms of multiple parameters with the exception of age. Those receiving therapy were slightly younger than the control group. These other demographics were all similar patients received ICDs, the QRS width, et cetera, as you can see here. And here are the data, totally flat. This is a left ventricular end systolic volume index. The control is red, therapy is in blue, and the lines are parallel and do not change at 6 months. This is peak VO2. Those data are flat as well at 6 months. This is NT-proBNP. Those data are flat in both groups at 6 months. Additional objectives, freedom from hospitalization, quality of life, New York Heart, 6-minute walk, no difference and no change at 6 months. This is the actual data for the 6-minute walk in these patients. Adverse event were the same in both groups. Left ventricular end diastolic volume index and ejection fraction did not change as one sees here. This is now, I didn't show these data at the heart meeting, this is now at 12 months and nothing changes. This is end systolic volume index, peak VO2 at 12 months, pro-BNP at 12 months. Survival was not different in the two groups. So, based on these data, spinal cord stim at 90% maximum tolerated threshold in the population studied does not appear to offer any clinical benefit. Does this invalidate the hypothesis? Well, one can challenge the study was low power, but the statisticians tell me enough to establish neutral effects. Incorrect dosing, I'm going to come back to this. We only stimulated for 12 hours with a single lead, and perhaps we didn't dose the patients properly. Perhaps they should have had a higher output or even 2 leads. Were patients not followed long enough? Well, 6 months, 12 months, no change. I don't think that's an issue. Impact of a single center, I don't think that played a role. Excluding prolonged QRS complexes, well, possible, but I don't know. Was the left ventricular end diastolic dimensions not large enough? These are standard data from heart failure trials, and Doug Mann was our heart failure advisor and had no problems with that. So, Thomas Huxley said, "The great tragedy of science is the slaying of a beautiful hypothesis by an ugly fact." But have these facts slain the hypothesis, or have we not tested the hypothesis appropriately? And let me show you a couple of other data in my final slides. Hung Fat C, who was on the program, is he here? Okay, in any event, he presented this at a late-breaking clinical trial, 2014, and it was just published in Heart Rhythm. This was the same hypothesis as ours, to produce spinal cord stim in a multi-center pilot trial. Now, different. He stimulated the spinal cord for 24 hours a day, the same parameters we used, but had 2 leads, a midline and a right epidural electrode in these patients. And again, at the T1 to T3 level. Small study, not randomized, screened at 22, ended up with 17, followed those 4 who were not eligible. Well, that's not really a control, but nevertheless, they used those data. 15 subjects were followed for 6 months, but here are his data. Shown here, this is New York Heart, and 75%, 76% improved. This is quality of life, significant improvement. VO2 max improved. NT-BNP improved. Ejection fraction improved, and left ventricular systolic volume improved. So here are data that are totally different from ours. So we have 2 studies with different outcomes. one randomized, controlled, blinded, prospective trial with a negative outcome, ours, and the other small, non-randomized, prospective with 2 leads and 24 hours a day stimulation. And it reminds me a little bit of the renal artery denervation story for hypertension, with one very good prospective, randomized, controlled trial showing no effect on blood pressure, and a myriad of other trials showing improvement. So where do we go? This paper was just accepted for heart rhythm 3 days ago, and it's probably online now, knowing Peng. And I wanted to show it because it was a beautifully done study. It's from China at the Wuhan University in dogs, and they showed dogs with an infarct showed suppression of ventricular premature beats, suppression of ventricular tachycardia, the duration of VT was shortened, and this shows suppression of ventricular fibrillation. But one of the things that I liked most about this study, and they took off on some of the pioneering work that Peng Chen has done, recording spontaneous stellate ganglion activity in the awake, conscious, ambulatory dog. And they demonstrated that spinal cord stimulation suppresses spontaneous stellate ganglion activity in these dogs. So either this could be a direct effect, as the early slide by Patterson et al. Showed, or it could be via an accentuation of vagal activity. But nevertheless, they show a beautiful mechanistic explanation for why spinal cord stimulation could have such a beneficial effect. Here are the quantitative data showing spinal cord suppression of spontaneous stellate ganglion activity. So where are we? Based on copious animal and some clinical observations, in my opinion, we did not slay the hypothesis, but merely wounded it. Another randomized clinical study with different spinal cord stimulation parameters, I think, is needed. But to get Medtronic or some other company to support an expensive prospective trial with a well-done clinical trial with negative outcome will be difficult. And with that, I will stop, and thank you all for your attention.